welcome once again to this special edition of our CPAN Week Day. And I hope we'll be able to celebrate our profession in one way or the other. And whatever it is we need to post today about pharmacy profession before we sleep tonight, I wish we'd do that. So our presentation tonight is going to be herbal drug interactions in clinical management. And we have our special guest tonight that's going to do justice to this topic, a pharmacist all the way from North Carolina, United States of America. He is Dr. Pius Fasinu, an assistant professor of pharmaceutical science, College of Pharmacy and Health Sciences, Business, Campbell University, North Carolina, United States of America. You are welcome, Dr. Pius Fasinu, sir. So without taking much of our time, we are just going to listen and prepare our questions that we have without making any objections during the preparations or during the presentations tonight. When the presenter is through, we could bring all questions we have, and probably he's going to do justice to it. I welcome all the clinical pharmacists all over the world, in Nigeria, in diaspora, all our senior professors, clinical pharmacists, CPAN coordinators, ladies and gentlemen, both active members and every member present tonight. Once again, I welcome you, Mr. Presenter. You are welcome as we prepare ourselves for this special presentation tonight. Thank you, sir.
Thank you, Dr. Peter. Can everyone hear me?
Yes, we can hear you. We can hear
you. Okay, thank you. A few things before I go on. I want to ask you, how many minutes do I have for this presentation? And can I share my screen?
Yes, you have been permitted to do that.
You can do that, sir.
Okay. And then how long can this take?
Okay, we're looking at 45 minutes to 1 hour. 1 hour is good, sir.
Okay, sir. All right. All right,
yes.
Thank you.
So we can have questions and answer sessions afterwards.
Okay. So thank you. Thank you for your time, everyone. And thank you for all that you all do, especially as you practice and at the same time promote clinical pharmacy in Nigeria. My name is Pius Fasinu. I'm a 2005 graduate of Olabisi Onabanjo University School of Pharmacy before I left for my graduate studies, first in South Africa, before I came to the US. First, I was at University of Mississippi for my postdoc before I came to Campbell University as an assistant professor. There is a minor error in the the minor stuff in the calculating announcement. I saw College of Pharmacy and Health Sciences Business.
Yeah.
I don't know how that word business crept in, so I think it's an error.
Okay, sorry about that.
All right, so it's just College of Pharmacy. Okay, sir. Yeah, no, I saw it. It's not your mistake. So just College of Pharmacy and Health Sciences, Campbell University.
It's okay.
Again, congratulations to everyone and happy World Pharmacist Day to
World Pharmacist.
Let me try to share my screen now. All right, so is my screen visible to everyone?
Yeah, it is. It's visible.
All right. So thank you. All right. So the title of my presentation is Herb Drug Interaction, and I assume that most of us are very familiar with drug interaction, and some of us might actually be familiar with herb drug interaction too. But it might just be an opportunity to refresh ourselves on how important this is and how to handle it in research and in practice. So for this presentation, as usual, I have no conflict of interest here. If I mention any drug name or brand name or anything like that, is just for academic purpose. I don't promote any product at all. So I have no conflict of interest that is directly or indirectly related to this presentation. And here are my learning objectives. I want that at the end of the presentation, we should all be able to identify help-drug interaction. I call that HDI for short, and be able to see that as an important, or probably one of the most important risks when our patients combine prescription medicine and herbal supplements. I want us to be able to outline mechanism of action or how help-drug interaction can take place, and be able to provide examples of such interactions in practice and what has happened in the past. I will show a few examples, and also be able to identify ways to mitigate or to manage help-drug interaction when they occur. So I have 3 cases I want to quickly run through, and then I will make reference to them later. Okay, I'm not going to discuss this in detail now. So here's a 46-year-old female who has been stabilized on warfarin, 56 milligram every week in total. And their INR, the international normalized ratio, has been maintained an average of 2.0. That's with a range of 1.6 to 2.2, which is okay. But then today, as on this current clinic visit, they have an INR of 4.6, and she admitted that she had been drinking 1 liter per day of cranberry juice for the past 2 days. Okay, a few things to note: that 14 days ago, she had an INR of 2.3, which is in the normal range. And then for the next 3 months, while taking warfarin, okay, I don't know if I'm missing up reading this. Maybe if I just read it straight away, it will be fine. But I'm just trying to bring out the important thing I want to bring out. Okay, so let me just read it from that second paragraph. So her INR 14 days later without cranberry juice was 2.3. And for the next 3 months, while taking warfarin, same dose, the INR was 2.1 in a range of 1.4 to 2.5. So at a subsequent visit, after drinking approximately two quarts, that's almost 2 liters per day, for 3 to 4 days, her INR increased again to 6.5. Her INR after holding warfarin for 3 days was 1.86. And then it became 7 days after resuming the weekly dose of warfarin, INR became 3.2. That is after he stopped taking the cranberry juice. Okay, again, during both of the elevated INR episodes, no other factors were identified that would have resulted in the changes in the INR. No new drug was taken, no change of diet. Okay, so that helps the physicians or the clinicians to ascertain that the only change that would have caused the change in INR will be the cranberry juice that the patient started consuming. Again, no for warfarin, to monitor the risk of bleeding and to also make sure that the risk of cardiac event is reduced. We usually want to maintain an INR of between 2 and 3. In people who don't have any problem, INR is like 1 in them. But the higher the INR, the higher the risk of bleeding. And if it's too low, that means the patient will have a higher risk of clot formation and cardiac events. Okay, so that is case number 1, is between warfarin and cranberry. So I have a second case. Again, this is not just some case that was formed in the mind. You can see the reference there in that slide is a case that was published. So you know that it is real. And then the second one too, also published. This one is a Journal of Clinical Pharmacology and Therapeutics. It's about a Hispanic man in his 30s who was already well controlled on warfarin. He was taking it for his mitral valve replacement. His INR increased from 2.64 to 4.12. He denied changes to his medications and diet and noted starting a liver cleanser. In this case, you see the medication I displayed here, milk tissue. That was what he started taking. But after, of course, this is a long it's a long case. You may want to read it. That's why I put the references there. I can also supply them on request. Okay, so but the long story short is that after stopping the supplement, his INR normalized and he remained on the same warfarin dose. Okay, I don't want to bore you to death. I only have 3 cases. Okay, this is the last one. 78-year-old Hispanic man with a history of diabetes, hypertension, and a deceased donor renal transplant, which happened 5 years earlier before the visit. So he presented today to the renal clinic for a regular follow-up. No complaints were reported, and the physical exam was unremarkable. The labs were taken a week ago, and they were significant for tacrolimus level of less than 3 nanogram per ml, with a serum creatinine of 1.2 milligram per DL. So his current meds include tacrolimus 2 milligram BID and mycophenolate 500 milligram BID. So on further inquiry, the patient admitted taking herbal medication, Baldo. You see the diagram, the picture there on the screen. He was taking Baldo 300 milligram BID for the last few weeks. Otherwise, there were no changes in his regular medications. He has been adherent. He's been taking the tacrolimus from the same company, the same pharmacy, the same brand for over a year. Okay, so the end of the story is that 1 week after he stopped taking the Baldo, his tacrolimus level went back up to 6.1 nanogram per ml while taking the same dose. All right. So those are the 3 cases I'll make reference to again in the course of the presentation. Are we still together? All right, thank you.
Yes, please continue. We're together, please.
All right. So, as a way of introduction, everyone know that herbal supplements, traditional medicine, the use is on the rise. And in the past, I used to say this thing as maybe an African thing. That Africans, we like to use herbal medicine. We use a lot of agbo, but it is not actually so. In fact, I have a graph, I have a chart I will show you later. You want to see that in Germany, in most parts of Europe, even in the US here, they supplement a billion-dollar business, and people take this thing very, very, very well. It's very popular among several patients, regardless of what they are treating. Cancer patients, HIV/AIDS, cardiovascular disorder patients, no. So they take this. And so what I have here onto the right is a list of the top selling herbal supplements in the US. You see Jingo take the lead for the last year. It changes every year, but usually these are consistently in the top 20. Jingo, echinacea, garlic, ginseng, soy, saw palmetto, St. John's wort, valerian, and so on, as you can see them, right? And now the only difference is here is that you see them, they package this thing, they formulate this into capsules and tablets. Okay, so beyond that, it's just the same thing that people take back at home. I know there are several formulations like this back home in Nigeria and in Africa, but also the raw extract are also very popular with our people. So, but again, there's no difference. They are taking the same thing, just that with formulations, you can actually estimate how much they have taken. That's the only difference. Okay. So this is the chart I referred to earlier. So you see here, what I put together is what is in the literature as how many people, what proportion of the population take herbal supplements in one form or the other. And you will see that. See, apart from, say, rural China, where you have close to 90% of them take herbal medicine, you have India there, you have Africa in the range of 80% of the population, okay, taking that. Then we have, you see the chart there for Germany, and the average for the whole world based on WHO chart is around 70%. Okay, so we're talking about people who take this as supplement or who take them with their regular meds, for whatever reason, for whatever the indication may be. Okay, so this is not something that should be ignored by the health community because of the sheer popularity of them. Okay, so the issue that we are talking about today is not about the effectiveness of traditional medicine or how great or how how bad or how safe or how unsafe herbal medicines are. That is not the crux of our discussion today. Okay, so the discussion is going to center about herb-drug interaction. And then before we define that, so I want to say this quickly. So for many people, you know, when they go to the clinic, they don't tell their doctors or the pharmacist that they're taking herbal medicine. They don't get those one by prescription. Okay, so in most cases, they take their prescription medicine, they go home, but they continue to take their supplements. The same way they don't tell us they eat, and the same way they don't tell us that they are taking vitamin C, which is over the counter. You know, that's the same way they take their herbal medicine, because it's assumed generally that these are mild and safe and they're not drugs, in quote. Okay, so concomitant herb drug use, that is the combination of herbs and prescription medicine, is very popular. And we don't have sufficient data for every country, but the few I could find, one study I found in the US here says 38% of Americans combine their prescription medicine and herbal medicine together when they administer. I found another study among the Israelis. That's close to half of those who take medicine take them in combination with their herbal meds. And here I'm not talking about the practice of using both. I'm talking about the combination, concomitant, concurrent use. I have another one is from South Africa. 32% report using their ARVs and herbal medication. Okay. Again, I have a point here. 75% patients do not disclose this to their health professionals. Okay, unless you ask. If you don't ask, not that they are keeping it secret, but usually it doesn't. There's no reason to say it because it's just seen as a normal thing, the way they eat their food. All right. So that becomes very important. When you clock a patient, you want to find when you get to medical history, you also want to ask about vitamins and the herbal supplementation. Okay, so what is the problem if somebody combine many drugs? When we talk about polypharmacy, we always talk about herb-drug interaction, because we see when you take too many drugs at the same time, there is the probability that they will interact one way or the other. So when you take herbal supplement and your prescription drug concurrently, there is the risk for herb-drug interaction. That is the last point there. Herb-drug interaction have been identified as the single most important clinical consequences of herb-drug combination. All right, so what is herb-drug interaction? Herb-drug interaction is defined, it has a very similar definition like drug-drug interaction. Okay, it's a measurable modification that will be in magnitude or in duration of the action of a drug by a prior or a concomitant administration of a herbal product. And that could be a herbal supplement, it could also be herbal nutritional. Okay, like drug-drug interaction, HDIs could be desirable. In few instances, right, clinicians may ask patients to take their medicine with orange juice or with grapefruit juice, or may take them with St. John's wort, you know, depending on what you have in mind, at least, but you know that there will be interaction, just that interaction will be therapeutically beneficial. But in most instances, it's not desirable, it's adverse. And in some other instance, it's just inconsequential. There might be interaction, but it's not important for you to make any adjustments or to make any clinical intervention. So how did we come about the subject of herb-drug interaction? You know, it's relatively new because we are familiar with drug-drug interaction. Herb-drug interaction was not a thing until, let's say, in the early 90s. And these guys in Canada, Bailey's group was conducting a clinical study on felodipine. And in felodipine is this yellowish tablet, and is bitter, has an unpleasant taste. So during the clinical trial, some of the patients, some of the subjects complain about the taste. So here, the group asked them to use grapefruit juice instead of water, so that can conceal the bitter taste of felodipine. Okay, so that was how the clinical study was conducted. And then when they got to analyze the result, those who took felodipine with grapefruit juice, they had up to 3 times the blood level, the plasma level of felodipine. And that got them curious that what happened? What could grapefruit juice have done to felodipine in those patients? And basically that gave rise to what the concept we now understand as herb-drug interaction. Okay, so if you do a casual search on the regular research publication databases, say PubMed, which is the most popular one. So like that's what I did here, and I picked this diagram from my a publication I had last year in Frontiers of Oncology on herb-drug interaction. So what I did with my student was we tried to search for herb-drug interaction. Let's say in the 1980s, you will not see any publication that mention it up until that 1990 when these guys did this study. And then after that, people got interested in this area of study, and then you can see how the graph pick up, the chart pick up. Like we have a peak there around the year 2008, okay, where we found about 125 publications, okay, that were published that year on the subject of herb-drug interaction. Again, and after that, maybe it has come down, but now it's kind of stabilized. It has become like part of a scientific subject. So it's now is now part of our daily discussion in clinical management, in research, that we have to consider herb-drug interaction. Okay, so again, I put there that HDI is now a medical subject heading. So if you are familiar with how PubMed search is done, okay, it's now a very common, what I will call keyword, okay, in scientific community, okay, unlike before, right? So that is as a way of explaining how HDI comes to become important consideration. So what's the mechanism of herb-drug interaction? What happens? Okay, so when you take herbs, just like drugs, they can interact with other drugs via pharmacokinetic means or pharmacodynamic means, okay? So let's talk about pharmacokinetic means. So PK, generally, we talk about absorption, distribution, metabolism, and excretion, okay? So you can have a herb that can change the pH of the GI compartment, and for drugs that are absorbed via pH-dependent mechanisms or that are very sensitive to changes in pH, you see there will be changes in the way they are absorbed. Okay, that is how that HDI can happen and affect absorption. HDI can also cause complexation. You know, we have that with drugs too. You know, the common one we talk about tetracyclines or quinolones with polyvalent metals like calcium, aluminum, magnesium. You know, they can complex tetracyclines or quinolones and probably inhibit the absorption because of the chelates. Okay, so it is possible. We can have that. It's rare, but we can have that with herbal preparations, depending on what is in there. But by far, the most important one when it comes to absorption is that, you know, in the GI there is a rich expression of cytochrome P453A4. There is also a rich expression of P-glycoprotein, efflux protein. Okay, so now we know, because like that instance I told you about felodipine and grapefruit juice. So what was happening was that grapefruit juice contains those phytochemicals that are able to inhibit the action of P-glycoprotein. P-glycoprotein is an efflux pump. Okay, so when you inhibit it, that means that more of the drug can be uptaken by the cells. That will increase absorption. And that was what happened in the case of felodipine when it was given with grapefruit juice. So that is one. So second way will be distribution for PK consideration. It is possible, not a lot has been reported about that, but it is possible that phytochemicals are able to displace other drugs from binding sites, and that may increase free concentration of the drug. So that is a possibility. We consider that as a possible mechanism. But the most important mechanism so far is metabolic interaction. Generally, a drug can inhibit the metabolism of another drug. that will lead to the accumulation of the victim drug. Okay, so that can happen with herbs too. So we now know several phytochemicals that can inhibit metabolic enzymes, especially cytochrome P450 enzyme family. And we also know those that can induce. So if you induce, that means that the victim drug will be metabolized faster, right? And if you inhibit, the victim drug will accumulate because it doesn't get to be metabolized as it's supposed to. And then excretion, because when there's interaction either from the point of filtration in the glomerulus, or the uptake in the renal tubules, or active secretion into the renal tubules, phytochemicals can interfere with that. Just the same way we talk about probenesis enhancing the excretion of, say, uric acid, or preventing the elimination of penicillins, for example. So those are things that phytochemicals can do too. So this diagram, I used this in the class, but I don't think I need it now. I think I've said everything I need to say about that. So generally, herb drug interaction can affect bioavailability. So you can see the digestive system here. And by now, everyone is a pharmacist, so we know about the proximity of the GI wall to the portal vein. So that means that reminds us of our first pass effect of drugs. And then we know that our dosage forms and doses are designed to take into consideration first pass effect. So if we mess up with how much of the drug is lost in first pass reaction, that means that we change drastically the plasma concentration. I don't know if I said that right, but what I meant to say is that we already know if you are given 20 milligrams of felodipine, for example, we know felodipine has a bioavailability of just 20%. Okay, so if you are given a herb that inhibits the P-glycoprotein, and then you now have more felodipine being absorbed, that means that you're going to have a high level of felodipine compared to if you did not inhibit P-glycoprotein. Okay, so these are different points where interactions can actually occur in the GI, in the liver, that can affect bioavailability. And we're also talking about in the enterocyte, where we have a rich expression of efflux proteins. Okay, and so that's generally will give us an idea of what is going on. Enzyme inhibition, enzyme induction are the primary mechanism of herb drug interaction. Okay, so I want to give you an example of enzyme inhibition. So I go back to that that narration I gave you. I just told you about Bailey's group and felodipine study. So this graph is from their study. That study, which was continued several years. So this one was the one from the publication they had in New England Journal of Medicine in 2005. Okay, it's just the same story. So you look at the first profile there, the one that has the white rectangle representation. That is the PK, or what I would call the concentration time profile of felodipine in the patient that took felodipine with water. Now look at the other one that has the black dot representation. You can see the levels of felodipine in plasma in patients who took felodipine with grapefruit juice. So when you calculate the AUC there, you can see the significant difference. Now for felodipine, I don't know, it may not be a problem, but for drugs that have very narrow therapeutic range, this is going to be a big problem. Okay, so that is what happens when there's enzyme inhibition. Okay, there is in this case, there is inhibition of CYP3A4 that metabolizes felodipine. There's also the inhibition of P-glycoprotein that is supposed to cause first pass metabolism or reduce felodipine absorption via pre-systemic mechanisms. Okay, that is one. The second example I want to show will be about enzyme induction. So I mean there are phytochemicals that can enhance the activity of those metabolic enzymes. What they do that by two different ways. On long-term exposure, the body tend to enhance the production of the enzymes. So that means the enzyme levels will go up. And that means that the drug can be metabolized, the victim drug can be metabolized much faster. The other instance can be the phytochemical can actually induce the existing enzymes to actually metabolize the drug at a faster rate. Okay, and I know this is very popular with, I know one herbal product that is very well known as an inducer, St. John's wort. St. John's wort is widely used, especially in the US here, as a supplement to treat depression. And there's a lot of study to show it actually works. Okay, but the problem is that it is a potent enzyme inducer. So we always use that as an example. We can use grapefruit juice as an example of enzyme inhibitor. But when it comes to inducer, we usually talk about St. John's wort. You know, for drug-drug interaction, we talk about rifampicin, all those phenytoin, and those other anti-epileptic drugs, which are known enzyme inducers. For herbs, we talk about St. John's wort. Okay, and I remember some times ago when some guys presented this about St. John's wort in some women who were taking the regular contraceptives, and then at a point they started taking St. John's wort, and what happened in them was that St. John's wort was enhancing the metabolism of the contraceptives, and of course with time the blood plasma level of contraceptives will go down, and that will lead to contraceptive failure. And that's what I have here. Is when you take other contraceptive and St. John's wort, you're going to have miracle babies. And that is not even funny enough, because I know that the journalists who were present at the presentation, the way the guy reported it was that St. John's wort can make you pregnant. All right. So that is my example for St. John's wort. So the other mode of interaction or mechanism is generally pharmacodynamic. Okay, I've talked about pharmacokinetic mechanisms to include absorption, distribution, metabolism, and excretion. So the other mechanism will be pharmacodynamic. You know that the herbs are actually taken for specific indications. So I just talked about St. John's wort, for example. It actually works. It helps in depression. Now, if somebody is taking some other antidepressants, so yeah, we're going to talking about some, at worst, there might be some synergy, but at least there might be some addition, there might be some additive effect. So that you will consider that to be pharmacodynamic in nature, okay? Even though there might not be a direct interaction between St. John's wort and the venlafaxine or the bupropion or whatever the drug is, okay? So pharmacodynamic interaction occurs when the herb is able to either potentiate or antagonize the victim drug at the receptor site, or can potentiate it at another site, like somebody taking caffeine, and they're also taking Valium. You know, caffeine will keep you awake. Valium wants to make you sleep, but they're not working at the same receptor site. Okay, that is an example of interaction. There can also be alteration of fluid electrolyte environment, which may disrupt how the victim drug works. Right? Again, so I've been told that we'll have our questions at the end. But okay, usually I don't talk for this long before I pause, just to be sure that I still have my audience with me. Okay, so but I will continue. If you have questions, please note them, and we can talk about them at the end of the presentation. All right. For clinical pharmacists, I think it's good to note this slide. When I was doing my master's, I was doing primarily an in vitro studies of cytochrome P450 using liver enzymes and hepatocytes and those kind of interaction studies, you know. But later, when you start doing working, dealing more with patients or in trials, it's not everything that happens in the lab that translates to clinical significance. Okay, so and that is why I put up this slide. That table I took it from one of my publications in the where is that again? Frontiers in Pharmacology. Okay, what I'm driving at here is that if you rely on literature, you find a lot of herbal products. They will say they inhibit 3A4, inhibit 2C9, inhibit this enzyme and like. there can be inhibition in the lab, but it may not translate to inhibition in the patient. Okay, so we want to focus more on the studies that are clinically significant, where it has actually been shown that a patient took this, and there was some interaction. It can be either in form of clinical studies or can also be in a case report. Okay, like those 3 cases I gave initially, they are all case reports that were published by clinicians. Okay, so there are published theoretical proof that there can be interaction. Like for now we know that grapefruit juice, for example, inhibits P-glycoprotein. So it just makes sense to assume that any drug that is a substrate of P-glycoprotein will be a candidate for interaction with grapefruit juice. Okay, that is fine, but it will not be clinically important unless we can prove it in the clinic, in humans. Okay, so that is the least form of evidence. The next one would be, okay, it has been shown in the lab actually that when I give simvastatin and grapefruit juice can inhibit the metabolism of simvastatin in the lab, in my plate. But then that is another level of evidence, but I won't take it as the most important one. Then there can be well-documented published case report, like I just showed you now. If you have sufficient number of case report, yeah, that should make a pharmacist or any clinician take action. Okay, cases have been reported with this combination, so you want to be careful in your patient. Okay, but the most reliable evidence will be a controlled clinical studies. When that, even though the one with Bailey was accidental, but when you have patient like that, you take your felodipine with grapefruit juice, and you take yours with water, just because we are trying to investigate the effect of grapefruit juice on felodipine. Okay, so we rely on the last 2 evidences more in clinical practice. We want something that is reported in patient as a case report, we can have case series, or something that is reported in clinical trial or clinical study. Okay, so here are a few other examples. I won't be able to exhaust all the examples because the objective of this presentation is at least get us familiar with this and know that there are several examples. And one of the objectives is that you should be able to highlight a few examples. So that's why I'm putting up a few examples here. So all of these are from published study. Asian ginseng interacting with warfarin. We saw cranberry and warfarin in one of the cases I presented before. Okay, and the reported effect is that there is increased thrombolytic event. Okay, depending on what the herb is doing. If it is inhibiting warfarin metabolism, then there will be bleeding. If it is inducing warfarin metabolism, like in this case, Asian ginseng can induce cytochrome P450-2C9, which is the one that actually metabolizes warfarin. So when you induce that, warfarin gets metabolized at a faster rate, okay, then the patient is not actually cardioprotected. And then there can be increased risk for thrombolytic events. So there is the elderberry that has diuretic effect on its own. So that's an example of a pharmacodynamic interaction that has been reported. It causes addictive diuretic effect in patients who are on diuresis, or who are taking diuretic agents. So garlic and ginseng, they are known to increase the bleeding risk in patients who are taking antiplatelet agents like aspirin, or who are taking anticoagulant like warfarin or the DOACs. Golden seal, is a known inhibitor of 2-DC, and 2-DC is the one that metabolizes codeine, for example. Codeine is generally a prodrug. So if it doesn't get metabolized, you don't release the morphine, and so you don't have the analgesic effect. So golden seal, when taken together with codeine, for example, the patient will not feel the analgesic effect of codeine because the codeine is not being metabolized to morphine. However, if you consider SSRIs, for example, the selective serotonin reuptake inhibitors, okay, if you prevent their metabolism, you should be expecting some serotonin syndrome, because this drug will accumulate, okay, and then you're going to have a lot of, serotonergic transmission will be enhanced. So several other examples there. I put the mechanism there. Green tea and green tea is known to contain vitamin K, for example. And you know, warfarin is a vitamin K antagonist. All right, so that is like an antagonistic interaction. And I have 2 enzyme inducers here. St. John's wort, I already talked about that. The one I say can get you pregnant or can make people have miracle babies. And then kava, that popular hepatotoxic herbal supplement, is also known to induce cytochrome P450 enzymes. So if given with benzos, for example, they can increase CNS depression, because that increases they can increase CNS depression by themselves and by their action on benzodiazepines. Okay, that means the drugs will not work because they get metabolized I'm sorry, I'm missing that up. Kava is not an inducer, kava is an inhibitor. Okay, so it causes accumulation of benzos, okay, and that will increase CNS depression, CNS depression, respiratory depression, and also those other side effects you expect at high, when you have high plasma levels of benzodiazepines. All right, so those are some examples. I want to talk specifically about, I think I have 2 specific examples I want to talk about warfarin. And the reason why we usually pick out warfarin is it's very widely used on outpatient basis as anticoagulant. It has a narrow therapeutic range. We always want to maintain, we usually don't measure the plasma level, but we want to measure the bleeding time. We use INR to measure the international normalized ratio. For patients, most patients, we want to maintain 2 to 3 of INR. And the higher the INR, the higher the risk of bleeding. And the lower, the higher the risk of thrombotic event. Okay? And because it's taken outpatient basis, you want to take note that, okay, that can be a representative narrow range drug for hep drug interaction to talk about. So one thing to know about warfarin, it is generally metabolized not by 3A4 but by 2C9. Okay, and what will happen? I know for warfarin generally, in the US, one of the things that most pharmacists graduate knowing is that with warfarin you avoid the 5 Gs. So those 5 Gs are what I put here. You avoid jingo, you avoid garlic, you avoid ginseng, you avoid ginger, you avoid glucosamine. All of those things can increase INR. That's the spelling error there. Increases IR. I meant to write INR. And the way they do that, right? The first 4 actually can inhibit the metabolic. So warfarin will accumulate. There will be increased INR. There will be increased risk of bleeding. Okay. Glucosamine itself, I think it has some. It's not very clear, but it has some direct effect on bleeding, and also increases INR. On the other side, if you talk about enzyme inducers, St. John's wort, for example, can induce 2C9, and that will enhance warfarin metabolism, and that will bring down INR very fast, and that will predispose the patient to increased risk of thrombotic events. All right, so that is that. So now go back to our case. What happened in this patient? Okay, he's been stabilized on the warfarin for a long time, and the INR was good, average of 2, 1.6 to 2.2, looked perfect. And suddenly he bought some cranberry juice, took a lot of that for 2 days, and then the INR went up. Okay, it went up to, let me quickly check that again. 4.6. Okay, I'm the one covering the 4.6 first, and then you will notice that in the clinic they didn't really do much there. They suspected, but they were not sure, so they asked him to stop taking that cranberry juice, and then the INR came down. Okay, after 14 days, and then he was asked to take it again. Okay, you can go ahead and take your cranberry again. I think we have taken care of everything we suspected. Now that your INR is fine, go ahead and live your life. You can take any juice you want. He took the same juice again, and then the INR went back up. Because that is going to bring us back to clinical management of HDR. Because sometimes you want to be sure it is the herbal supplement, and so you ask them to stop, and then you do a rechallenge, which is what happened here. Okay, so they can be more confident now that it is the cranberry juice that was increasing the INR. Okay, and what is happening here? Cranberry is inhibiting cytochrome P452C9. So that means the 2C9 is not metabolizing warfarin. Warfarin is accumulating. Bleeding risk is increasing. Okay, it's a very similar scenario with the second case. Okay, he's been stabilized on warfarin. INR of 2.64 suddenly went up to 4.12, which is out of the range. There is increased risk of bleeding because he started using milk tissue supplement. Okay, so he was asked to discontinue, and then INR normalized. Again, same thing. Milk tissue is inhibiting 2C9. Then the third case is about tacrolimus. So tacrolimus is an immunosuppressant that we usually use generally for renal transplant. So in patients who usually switch between cyclosporine and tacrolimus to prevent organ rejection after they have been transplanted with kidney. I'm sorry if I'm missing my words. I think it's 5 o'clock here, and I've had 3 classes today. So if I am stammering or stuttering, please forgive me. So tacrolimus is an immunosuppressant. The major problem with tacrolimus, just like cyclosporine, is that they are nephrotoxic. Okay, so that means that you want to prevent too high dose, not to destroy the kidney. Especially, this is somebody who actually received a kidney. That is one. You also want to prevent too low plasma because you don't want them to reject the organ. If the plasma level is too low, then the immune system of the recipient will not be suppressed enough to accommodate the received organ. Okay? All right. Tacrolimus is a substrate of 3A4. Warfarin, we said 2C9. It's 3A4 in this case. And we usually maintain that we do a TDM, therapeutic drug monitoring, take plasma levels to measure. You want to maintain between 5 and 15 nanogram per mil in the patient. If it is lower, you stand a risk of organ rejection. If it's higher, you stand a risk of nephrotoxicity. Okay, so that is the thing. You want to avoid an enzyme inducer like St. John's wort, so that you don't go lower than 5. And you want to avoid enzyme inducer like St. John's wort, and you also want to avoid enzyme inhibitor like, say, ginseng or garlic or ginkgo biloba. No. Okay, so let's go back to our case. What happened in this patient? He was already stabilized with tacrolimus after receiving a kidney transplant 5 years ago, and the last measurement was less than 3 nanogram per mil. Again, he has a serum creatinine of 1.2, kind of borderline. Okay, and he's been taking the same drug for a while, 2 milligram BID. But today, he has, okay, hold on for me. Okay, last taken a week ago was less than 3 nanogram per mil. Was the current med. On further inquiry, he's been taking Boldo. This is the herbal supplement. I have the image on the screen there. Okay, he's been taking Boldo for the last week. So what is missing from here is that he's been within range, within 5 to 15 range for a long time. And then he started taking this herbal supplement. So the last measurement, we have a value of plasma tacrolimus less than 3. Okay, so that's getting too low, right? So he was asked to discontinue. And after he discontinued, 1 week after, the level of tacrolimus went to 6.1. So what's going on here? The Boldo was inducing 3A4 and tacrolimus level was going down. And the patient was standing the risk of organ rejection because of poor immunosuppression. All right, so a few other things I may just mention this. So we do try to identify clinically significant herb drug interaction in the different systems. So for pharmacists, we actually have an ongoing project. We're trying to compile a handbook of clinically significant herb drug interaction people can use in different disease stages. So we have our oncology pharmacists involved, like infectious disease pharmacists, specialists involved, that we do that. So, but this is something I did with one of our PharmD students. Oh no, I did this, yeah, a PharmD student that was in Mississippi. We were trying to work on clinically relevant herb-drug interaction in HIV/AIDS. So we just compile a few of the herbs that have been reported through clinical studies. And I have the reference paper here as well. Something similar, you can see that in chemotherapy. You know, in the second column here, these are all anti-cancer drugs. But in the first column, you see all the herbs that have been reported to interact with those anti-cancer drugs. You know, for these drugs, of course, you want to maintain a therapeutic range in your patient, okay, to make sure the drugs are effective. So that's an example. And this one, I did this one with one of my students. This was last year for her PharmD project, okay. And so what I'm driving out here is that based on what I mentioned earlier about level of evidence, okay, so what we try to focus on here is what has been shown clinically to be significant to cause herb-drug interaction, not just in the lab. If you want to rely on in vitro lab, there are lots of interactions, okay? But then if you go by clinically significant stuff, you can just narrow them down to a few herbal supplements per disease state that you want to watch out for in practice, okay? I'm almost done, but most of this point, I already mentioned them one way or the other, that number one, you want to identify that a herb-drug interaction is going on. How do you do that? Usually your patients had no other factors. You want to rule out other factors, why they come and tell you this drug is no longer working. But it's been working. They've been taking it for several months or years. So suddenly it's not working. So you want to ask them what lifestyle changes have happened since the last time the plasma level was normal or the drug was working. Okay, so you want to do that. You want to identify any changes in their lifestyle or any new drug. Usually that's when they will tell you they started taking Jingo to enhance their memory or whatever the reason is. Okay, so when you rule out other factors, you can zero in on the herbal supplement addition that your patient has taken on. Then you want to identify the herb, and if possible, ask them to discontinue and watch out if the drug will work. You know, we are very quick to say the drug is not working, let's change it. But sometimes you just want to identify a factor that is making the drug not work. And then you can ask them to discontinue whatever they have started. And then if you're not still sure, like they did in that case that I mentioned earlier, rechallenge. Let them use the herb again after a few weeks. They should be able to tell you, oh, the drug stopped working again. Then you know that it is the herb that is interacting. And then to increase the knowledge, to share your knowledge with colleagues, if possible, talk about this in a conference, make a poster, or do a case study. What do you call it again? Present a case or publish a case. Okay, so that people can know that okay, if you reported it, they'll have to be on the lookout because there are too many herbs and they are made in different ways, and two formulations of the same herb may not actually be the same based on how they are processed, you know, things like that. Okay, so, but as a rule of the thumb, if it is necessary, tell your patients not to use herb and drug together. They can space the use. They can use one in the morning, the other one in the evening to avoid herb-drug interaction, okay? And if you already know that this causes interaction, like St. John's wort and contraceptives, that is, you don't need to wait for it, just let it be part of your regular counseling. Don't take St. John's wort with your simvastatin or with any drug that you know is a substitute of 3A4, okay? But again, in most instances, interactions are harmless, but they, you know, just like drug interaction, just that in those drugs that have narrow therapeutic range, they could be very dangerous, okay? So on that note, I am going to stop, and I made reference to publications, those case studies, and some of the places I took those graphs from, so I put them in this last slide. And I want to thank you for your attention, and thank you for your time too. It should be 10 o'clock in Nigeria, so it takes a lot of commitment to still be sitting in front of a computer or phone at this time. Thank you once again. Okay, are we still together?
Yes, we are still together. Thank you, Dr. Fasinu, for that one. I think we lost Dr. Afonso, who is the moderator for today. But in the meantime, it is a very good one, very interesting, very educative. At this point, I want to call on anybody with comments, contributions, and questions. You are free to unmute yourself or raise up your hand to ask a question, please. You are free, you're permitted. Raise up your hand and unmute yourself. So can you please stop sharing your
Doctor.
slide? Okay.
Hello.
Dr. Agbeli's hand is up.
Okay. Okay, for those of us that have questions, sorry, I'm back. We can actually raise our hands so that we make one or two inputs or ask one or two questions related to drug interactions, about drug interactions.
Kindly, Doctor, stop sharing his slides so I can see clearly. Can you stop sharing his slides?
Hello. Hello.
Okay, Dr. Andrew, go on.
Yes, man, it's not really a question. It's just that I'm feeling so bad that I have to miss the greater part of Dr. Pius' presentation. I just joined, doing some other things, and you know, he knows what I'm talking about. Trying to like meet some deliverables because of the fact of where I work. It's just very unfortunate that I have to like miss most of his presentation. I just came towards the concluding part of his presentation, but mine is not a question. It's just to like probably ask the chairperson of the CPAN Education Committee to please share these slides with all people, with all members, and for those who have actually missed this presentation, so that we can catch up and maybe probably read it on after the presentation has been concluded. It's just an appeal, okay?
It's okay. Thank you, Dr. Agbeni. We'll relate that to Dr. Timipre, and I'm very sure everybody will get it, including myself and any other person interested.
Thank you very much. Thank you very much. All right.
So one Dr. Person to stop sharing his slides so that you can see.
Okay. Yeah. Dr. Pius?
I'm here.
Yes, can you stop sharing your slide, Dr. Pius, for now?
Thank you.
Yeah, just withdraw your slide so that people can ask questions easily.
I think I've done that, right?
Okay, thank you.
Okay.
We have Dr. Felicia Williams raising up his hand.
Okay, so let's hear from Dr. Felicia Williams.
Please, can you go ahead, unmute yourself, please? Or unmute yourself, Dr. Williams, please, and go ahead. Unmute yourself and go ahead, Dr. Williams. I think we lost her. So can we call on Dr.
Let Maureen talk. Dr. Maureen Warford. Let's hear from Dr. Maureen Warford.
Okay.
So Dr. Maureen Warford, can you unmute yourself, please, and let's hear from you?
I've done that. Good evening.
Yeah, good evening, Dr. Maureen.
Good evening.
Yeah, good evening,
yeah,
Dr. Maureen.
I'm so happy to be part of today's presentation.
You're welcome.
My question is on population management. Do you hear me?
Yeah, he's listening to you.
Hello?
We're listening to you.
Okay. I manage anticoagulation in my hospital, and we're having challenges on maintaining therapeutic INR.
Okay.
But from our investigation, we found that our parents, they don't really take herbs. You know,
Hello, Dr. Maureen.
I think it's a network issue.
Yeah, it's like we lost her.
Network issue.
Hello, Dr. Maureen. Wow.
I think Dr. Williams is back. Dr. Williams is back.
Okay, fine. Let's hear from Dr. Williams.
we found that they used to take some vegetables. They're not basically, we cannot really call them herbs. These are normal vegetables. So I want you to throw more light. But there are some vegetables.
Wait, may not be clear, but I think I can hear part of her question.
Yes.
To go on?
Patients, yes. That the patients take vegetables and
Yes.
they have issues with their therapeutic drug monitoring.
Yes. So what is well known here, like the way we do it here, is that it's possible that two different factors, apart from herbal supplement, when it comes to warfarin and INR, one of the recommendations from on the labeling now is pharmacogenomics. For those several patients who are slow metabolizers of 2C9, or those who are rapid metabolizers or ultra rapid metabolizers. But again, in those patients, after you establish a given dose, there shouldn't be fluctuation anymore, because now, even if they are slow and they're taking higher dose, INR should be maintained. But the more important counseling point we usually do is that we don't ask people not to take vitamin K containing vegetables. We just tell them to be consistent. You know, if they are consistent in the type of vegetable they eat, okay, you will have established the right dose of warfarin. And once you establish the right dose of warfarin, that will be fine. The only problem will be that if they change the amount of vegetable they eat again, that means that the warfarin effect will be affected, depending on if they're taking more vitamin K containing vegetables or they're taking less. So the issue will be consistency in their diet pattern, which is very, is easy to do here in the Western world. Most of them have timetables on their fridges, and they have routine. They have food portion, but it's very unpredictable in our own type of society, where it's very difficult for people to say, oh, they eat vegetables only on Wednesdays and they don't eat it on Thursday. I know that's why I can understand why maintaining an INR will be challenging in that kind of environment.
Okay, thank you for that. I think Dr. Williams can now speak. Dr. Williams. Can we hear from Dr. Williams?
Ma, can you use your earpiece? We can hear you, ma. Dr. Williams, can you use your earpiece? We can hear you.
Dr. Williams, please, can you hear us now? I think we should go to Agbola Oguntola. Can we hear from Agbola Oguntola?
Good evening, everyone. My name is Agbola Oguntola.
Okay.
Okay, I work in the public health sphere. I'm in HIV. So I commend Dr. Fasinu, a very well delivered presentation.
Okay.
My own concern is what I noticed in the presentation was that virtually all the herbals had names and they were sort of predictable in their contents. So my question goes this way: how do we relate the kind of way an average client or patient will take herbals, which are not usually labeled. For example, you know what agbo and everything is, and some of these interact. So while we know they have taken some herbal medicines, but how do we identify precisely what they're taking? That is one. Then the other practice is that some take herbals through enemas. How far do we think herbals can interact through enemas? Thank you.
Can you say the last statement? Did you mean enemas?
Yes, I meant enemas. So how some
the
herbal
formulation? Okay.
Yeah, formulations that administered through enemas.
Okay. Well, the major challenge with the identification of the herbal supplement will remain in several societies where we use our extract from raw leaves, raw bark, raw roots, you know. But again, like I said, even in those ones that you see that are formulated, two formulations are not the same, you know, because the FDA does not require them to show anything except that the drug is safe. The supplement is safe. So if you are using same nature way garlic, if you switch it to another one, to another type, so you may experience a different interaction,
Okay.
different effect. So that may be similar to our community where people use agbo, which is more like raw extract from those from the plants. So on the clinical management side, I think the best way to do that is just to advise that they space it. Most drugs that they take once daily, that would be easy. You can do at least 10 hours apart. Your drug will be absorbed if you're taking it in the morning, and then you take your agbo maybe later in the evening. But if it's a drug that you take multiple times in a day, it becomes more challenging. Okay, probably if it's a chronic use, the patient may cooperate with you and suspend the taking of agbo. You're not going to tell them that agbo doesn't work. You're just going to tell them that two of them together may predispose the patient to toxicity, or things like that. It's not that the agbo doesn't work. We don't know. It does. If it works, maybe it does work. But our concern is that we can avoid concomitant use if we don't have sufficient information on the safety of concomitant use. On enemas, very few drugs are absorbed in the lower GI, so I wouldn't expect more. Also, most enemas are for localized effects. Usually, the most important drug interactions happen in the liver, which means that even the herbal product has to be absorbed, and then disrupts the metabolism of the drug in the liver. Again, of course, there are interactions in the GI when it comes to, but it has to be very specific. You have to reach that site in the small intestines where you have rich expression of cytochrome P453A4 or P glycoproteins. Of course, there can be other minor changes in the GI environment due to enema, like change in the pH and other things like that. But I wouldn't see that as a very serious potential to be considered when it comes to animals. Thank you.
Okay.
Thank you very much, sir.
Thank you very much. Is Dr. Andrew still raising his hand? Okay, fine, not.
Dr. Peter, that maybe that was the former hand I raised. Maybe I didn't drop it. Yeah.
Okay, fine, please drop it.
Okay.
So, Dr. Pius, are you still there?
I'm here.
Yeah, I want our chairman, Dr. Omadu, the chairman of CPAN, I want him to say something about herbal drug interaction today, because today is World Pharmacy Day and we need to hear his voice. Is Dr. Omadu around, please? Dr. Omadu, sir?
Good evening, everybody. Can you hear me?
Yes, sir, we can hear you.
Are you with me?
Yes, we are.
You want me to say something?
Yes.
Happy World Pharmacy. All pharmacists, especially those attending this Zoom meeting. I want to thank Pius Fasinu for giving us I have interest in herbal solutions. I think they are called natural pharmaceuticals. or so, I will really love to go through this presentation again. I have really enriched my bank of tonight, and I believe by the time I go through, and most of us as we are asking, we want to get the slides and whatever, I believe we shall learn more. So I want to thank all of you. I want to say Happy World Pharmacist Day to all clinical pharmacists in Nigeria. Remain blessed.
Okay, thank you, Dr. Madu. Dr. Madu has used this opportunity to talk about work pharmacy, but he didn't ask any herbal preparation or herbal product. I'd like to bring to our attention of Dr. Pius. We have some colleagues that are working on Moringa at the moment. They're doing clinical trials on Moringa. Moringa is one of the herbal products that is being used in Nigeria in almost all sectors. You know, so I don't know if Dr. Pius has any experience or any information about drug interactions of Moringa.
Okay. For that, first of all, allow me to take some liberty in addressing a question I saw on the chat room.
Okay, it's all right.
So I mentioned something about herbal supplements. I said including herbal supplement and herbal nutritionals. So somebody asked, what is the difference between the supplement and nutritionals? You know, the purpose of this presentation, the difference is that the herbal supplements are those that I show the formulations, those capsules, tablets of garlic, ginseng, St. John's wort, all of those. Okay, but I mentioned a particular example about grapefruit juice, which was what I said started all these studies on in herb drug interaction. Grapefruit juice is not taken as a herbal supplement for any medicinal purpose, at least in the generality of those who take it. You know, it's more like your orange juice. So that's what I meant by herbal nutritionals, because so we have several of them now, like that's the cranberry juice, although we have cranberry extracts formulations like that one that I showed interacting with warfarin. But then there's also cranberry juice that people buy and they drink. When they drink it, they don't believe they are taking it for any medicinal purpose. They're just taking their drink the way they take their water. So that's the difference for within this context. So the other question about Moringa. Moringa, I have he's done now. Charles Awoche is a Ghanaian. He was doing his PhD on herb drug interaction with Moringa in South.
Okay.
So again, he reported some interaction with Moringa extract, the methanolic extract, with 3A4 and 2C19 and 2C9. But again, those are the molecular level, I mean, in the plate, that's in the lab. As far as what you will consider clinically important, that we don't have any data yet. And that is something that I guess that maybe some of my future collaborations of students may look at. Now that we have some preliminary data, we are thinking about getting students that may work on that in humans. And that's something that's going on in our lab in South Africa. Okay, so for now, I don't know about any clinically significant herb drug interaction with Moringa oleifera.
Okay. Okay. Thank you for the question so far.
Dr. Peter Afonso.
Okay, Dr. Abeni.
Yes. This is just an information. There are 2 or 3 questions in the chat box. I don't know if Dr. Pius can go through them and possibly attend to answer those questions.
Yes, let him go through. It's okay.
Yes,
let him go
through. Chat box. I think I saw 2 or 3 questions there.
Okay, fine.
All right.
Okay, so I have a question here. You talk about possibility of spacing the herbal medicine while the patient is on the conventional medicine. Okay. So how many hours apart is reasonable enough? So here, you know, like when we suspect that there will be herb drug interaction via absorption. So the class I had this morning was about osteoporosis, and we're talking about the use of bisphosphonates. And I was telling the class how you have to tell your patient to take alendronate first thing in the morning before they eat anything, and they have to stand and not sit for at least 30 minutes and then not eat their breakfast until at least 30 minutes to 1 hour after they take the drug, and use only clean water, no juice, nothing else. You know, because of the poor absorption that we know for bisphosphonates. Now, if a drug is known to have very poor oral absorption, we always want to advise that don't take any herbal supplement. Even the one that we are not sure there will be interaction with, don't take for the next 1 to 2 hours, because we know that most drugs, even if they have low oral bioavailability, the absorption will have been reasonably complete in about 2 hours. Okay, so spacing can only help you avoid help drug interaction as far as absorption is concerned. If the patient is taking this drug on a chronic note for a long time, so with time it doesn't really matter, because even if you take it 6 hours apart, there will be, the body will establish a steady state with the herb and steady state of the drug. And then at that point, inhibition of the enzymes or induction of the enzymes in the liver will not be prevented. So within that context, on long-term use, spacing will help. Long-term use, spacing will not help, because both herb and the drug will establish some steady states in the body. Okay. That's how I think I can answer that question.
Okay, thank you very much, Dr. Pius, for answering this question so far. And this other time, from the cardiovascular point of view, that's my own area of interest. There has been reported some herbal drug interactions, specifically the same grapefruit you are talking about with amlodipine.
Yeah.
You know, it was reported recently from some, Canadian sites that patients that take amlodipine should abstain from taking grape. So I think that's one of the things I think we should remind ourselves with. I don't know if Dr. Pius has any information about that, different from what I've said, so that we could add that to our.
You know, when sufficient data was gathered on the interaction between grapefruit juice and felodipine, clinically it is safe to say that, number one, all dihydropyridine channel blockers, amlodipine, felodipine, all of them will have the same potential to interact with grapefruit juice. That is one. The second one is that if you want to be conservative. If you want to be very generous with the data, you can just say all substrate of 3A4 will be candidates for interaction with grapefruit juice, because you know what grapefruit juice is doing is inhibiting 3A4. So any drug that rely on 3A4 for clearance will accumulate if you give together with grapefruit juice. And most drug labels now, in fact, as a matter of requirement from the FDA here, you will see that it's written in the label, you should avoid grapefruit juice. You should avoid St. John's wort, because one is a known potent enzyme inhibitor. The other one is a known potent enzyme inducer.
It's okay. Thank you, Dr. Pius. I think we'll take our last question now from the.
I have a question. Yes. Thank you, Dr. Pius, for this brilliant presentation. Now, talking about grapefruit juice, you know, there are different types of grapes. You have this one that looks like an orange, and then the other one that is green, and you have the red one. So which one are we talking about?
Okay.
When we refer to grapefruits, yes.
So from those multiple studies, the only difference between those different subspecies or strains, or what would I call them, of grapefruit juice is the levels of furanocoumarins. Those furanocoumarins are those phytochemicals that have been identified, naringenin, bergamottin. So because the only difference is how much of those compounds each of the different species have. But the truth is that all of them have them to varying degrees. So that is why it's usually safe to say that any grapefruit juice will be able. Okay, of course, in detail, that means they will do it to varying degree because the concentration of the phytochemical doing this inhibition vary in them.
Thank you.
Thank you.
Okay, I think that's a very good one. We would actually appreciate Dr. Pius in no small way. We appreciate this presentation tonight. I'm very sure that World Pharmacy Day today is going to be celebrated in a different way. My personal appeal is this. We are medication experts in the whole healthcare team. I want us to use this as an opportunity, this herbal drug interaction, to make our mark. A lot of physicians prescribe some of those things or know little or not. I'm aware that some of these physicians are beginning to understudy herbal products. Please, we should not allow them know more than us in this respect. Because by the time the physician knows more than what a pharmacist knows, whether in the hospital or community pharmacy, then I don't know what we are going to be talking about, calling ourselves medication experts. So I think by the grace of God, Dr. Pius has reawakening us from the sleep. Remember his keywords. He said you, from the community pharmacy or hospital pharmacy or wherever you are, you can always charge and recharge. Was that what you said? Or is he awake and reawaken, Dr. Pius?
Yeah, that you can re-challenge, yes.
Okay, challenge and re-challenge. That is the take home.
Yeah.
You know, so even if it's case studies, whatever it is, don't just see and assume that nothing has happened. You can always re-challenge it again to be sure that it's actually a drug, herbal drug interaction. Please, we are not too small to make or bring new innovation in healthcare, especially in our climes that people take anything. Even if it's agbo, get a herbal man around and let him tell you the name of the agbo in whatever tribe you know. Write it and get people to bring opinions. We pharmacists should actually be up and doing. At this point, I will call our educational chairperson, Dr. Timi Pre, to, give a vote of thanks and say the closing prayer as well. Thank you. Dr. Timi Pre, are you online?
Yes, I'm online. Hello.
Dr. Peter.
Hello, Dr. Andrew. Yeah?
Yes, Dr. Peter.
Okay, Dr. Andrew.
Yeah, it is also, I want to reiterate this too. It is very, very important when we do our ward round, clinical pharmacy ward round, and you are taking your medication history. We should not forget to take the herbal history of that patient, what he has taken in the past is sent in form of herbal product. Okay,
awesome.
So that when you are making drug therapy intervention, you are going to process all those information together. Yeah, both the orthodox medicine, the herbal product this patient has taken, that will actually help you to actually arrive at the right intervention for that patient when you are making drug therapy intervention eventually.
Hello, please. Hello.
Okay. Okay.
Hello.
Yeah, is that Dr. Madu?
Hello, Dr. Peter. Can you hear me now?
Yes, let's hear from Dr. Madu before you talk, Dr. Timi Pre. I think Dr. Madu is trying to say something.
Yes.
Okay.
I can see one of our experts on herbal medicine, Dr. Okoye, who recently presented something to us on herbal medicine. I can see him raising his hand up. And I'm requesting to allow him to please speak to Dr. Pius Fasinu. I also want to use this opportunity to that by the time Dr. Fasinu's book with significant, clinically significant herb interaction, by the time the book is ready, you should please let us know because we will have the book. But please, can Dr. Chidozie Okoye be allowed to say something?
It's all right. Dr. Chigozie?
Yes, I'm here.
Okay.
I want to thank Dr. Pius for the wonderful presentation. My question is, though his presentation is on herbal drug interactions, but I want to know whether he has any experience in interactions between conventional drugs and potentized homeopathic remedies. Interaction between conventional drugs and potentized homeopathic remedies.
Homeopathy. Okay.
Yes. whether you have any experience in that area or whether you have done any research in that area. Thank you.
Personally, I have not.
Can I ask my question also?
Okay.
Can I add that?
Okay.
Wait.
So personally, I have not done a lot of research I've not done any research on homeopathic agents and conventional drugs. The only thing I can infer is that based on the well understood mechanism of drug interactions, so we can always expect drug, herb drug, food drug, disease drug, as long as they have a point of convergence. It could be pharmacokinetics, can also be pharmacodynamics. So because if we rule out that, let's say for homeopathic product mechanism generally, we may not see a lot of pharmacokinetic interaction, but we can see potentiation, we can see the additive effects, we can see synergy. So those are things that are potential. Those are potential areas that can be investigated, and I think it will be interesting to see what we find.
Is it okay?
Hello, can I ask my question now?
Okay, quickly, please, quickly. You can quickly.
The question has to do with the mechanism of action for the G's interactions with warfarin. I feel that apart from the pharmacokinetic mode of interaction, there's the possibility of pharmacodynamic interaction because ginger and garlic have the ability to cause bleeding on their own.
Yes.
So using them with warfarin can also lead to either potentiation or additive effect. So apart from the pharmacokinetics, we should also look at the pharmacodynamic aspects of these interactions. That's my contribution. Or what do you think, sir?
No, you're right, sir. I don't know if I didn't mention that, but because of the specific example that I used, the interaction was attributed to 2C9 inhibition, right? But for warfarin, you are absolutely correct. There are those drugs that on their own, they can inhibit the VCOR enzyme, the VCOR-C enzyme that warfarin inhibits, right? Number two, there are those other ones that can induce bleeding via other mechanisms. Could be through platelet activity or all those factors that may them. So, like I mentioned one, I talk about glucosamine, for example, when I said that the mechanism is not clear because we don't know it to inhibit 2C9, but again, it increases INR when used in combination with warfarin. So warfarin actually the interaction could be multiple. The mechanism could be pharmacodynamic, it could be pharmacokinetics.
It's okay. Thank you, Dr. Pius, for granting audience and for well-articulated answer. At this point, we want Dr. Timipre. Dr. Timipre, are you online?
Yes, I'm online. Are you hearing me?
Yes, so you're going to give a vote of thanks.
Can you hear me?
I can hear you. So you're going to give a vote of thanks to our presenter. At the same time, you give us a special closing prayer that has to do with the World Pharmacy Day.
Yeah, I just want to thank you, Dr. Pius Fasinu, for this very, very insightful presentation. Thank you so much. We really appreciate you. And I know you are going to share the slide. You are going to send me the slide so that I can share it all throughout all the CPAN WhatsApp group. Thank you so much. We appreciate this wonderful presentation. So we are going to round up now. We know today is the World Pharmacy Day. A lot has been going on in all the different states. People have been carrying out different, activities. So this is the little we can do this night for this our wonderful presentation. Even though it fell on a Friday, we want to thank God for every wonderful thing that has happened. So let's pray. Let's pray. Lord, we thank you for actually making it possible for us to gather this evening and also talk about our profession, things that are going to help us and help us to grow in our profession. Father, we thank you. This night we want to sleep. Father, we want to protect us and also guide us and also be with us. We ask you all this in Jesus' name. We pray. Amen.
Amen.
So thank you once again, presenter, and on behalf of the CPAN chairman,
Amen.
Dr.
So
Madu,
thank you so
and all
much.
the ESCOs, please, all of us should do something about herbal-drug interactions from now on henceforth. We shouldn't just discuss, then we should always put that in our, documentation platform, whether at the hospital or in the community, and it's going to be another angle of changing our profession. Thank you very much, and have a wonderful night rest, and good morning.
Thank you.
Thank you.
Thank you, CPAN executive. Please, let's go Zoom. Oh, Zoom. Zoom. Let's continue with this Zoom.
Okay, you prefer Zoom?
Yes, so.
Okay.
Thank you, Dr.
All right.
It keeps us awake.
Yeah.
Keeps you awake.
Yeah.
Keeps us awake. The other one induces sleep. Telegram is an inducer for sleep.
Okay.
Supporting me in Zoom.
Okay, we are listening. We'll do something about it. It's all right. Thank you for being part of it and asking for more.
Yes.
Yes.
Have a very wonderful weekend ahead.
You
Thank
too.
you. Thank you.
Please stay safe.
Bye-bye.
Good night and good evening.
All of the above. All right.